Hyperthyroidism in pregnancy. Clinical evaluation. Hyperthyroidism occurs in about 0.2 to 0.4% of all pregnancies. Most cases are due to Graves' disease, although less common causes, for example toxic nodules and thyroiditis, may be seen. Clinical assessment alone may occasionally be inadequate in differentiating hyperthyroidism from the hyperdynamic state of pregnancy. Distinctive clinical features of Graves' disease include the presence of ophthalmopathy, diffuse goitre and pretibial myxoedema. Also, hyperthyroidism must be distinguished from gestational transient thyrotoxicosis, a self-limiting hyperthyroid state due to the thyroid stimulatory effects of beta-hCG. This distinction is important since the latter condition is typically mild and will not usually require specific antithyroid treatment. Red cells Inc. may also be useful in differentiating the two. 25. Hyperthyroidism due to Graves' disease may worsen in the first trimester of pregnancy, remit in later pregnancy, and subsequently relapse in the postpartum. Risks of hyperthyroidism on fetal and maternal well-being. Uncontrolled hyperthyroidism in pregnancy is associated with an increased risk of severe preeclampsia and up to a fourfold increased risk of low birth weight deliveries. Some of these unfavorable outcomes are more marked in women who are diagnosed for the first time in pregnancy. A recent study has also shown that already high normal maternal FT4 levels are associated with a decrease in child IQ and gray matter and cortex volumes, similar to the effects of hypothyroidism. Uncontrolled and inadequately treated maternal hyperthyroidism may also result in fetal and neonatal hyperthyroidism. 26. Due to the transplacental transfer of stimulatory TSH receptor antibodies, TRAbs. Clinical neonatal hyperthyroidism occurs in about 1% of infants born to mothers with Graves' disease. Rarely neonatal hypothyroidism may also be observed in the infants of mothers with Graves' hyperthyroidism. This may result from transplacental transfer of circulating maternal antithyroid drugs, pituitary thyroid axis suppression from transfer of maternal thyroxine. Management of hyperthyroidism in pregnancy. Ideally, a woman who is known to have hyperthyroidism should seek pre-pregnancy advice, although as yet there is no evidence for its benefit. Appropriate education should allay fears that are commonly present in these women. She should be referred for specialist care for frequent checking of her thyroid status, thyroid antibody evaluation and close monitoring of her medication needs. Medical therapy with antithyroid medications is the treatment of choice for hyperthyroidism in pregnancy. Methimazole and propylthyracil, PTU, are effective in preventing pregnancy complications by hyperthyroidism. Surgery is considered for patients who suffer severe adverse reactions to antithyroid drugs, and this is best performed in the second trimester of pregnancy. Radioactive iodine is absolutely contraindicated in pregnancy and the puerperium. If a woman is already receiving carbimazole, a change to propylthyracil, PTU, is recommended, but this should be changed back to carbimazole after the first trimester. This is because carbimazole can rarely be associated with skin and also midline defects in the fetus, but PTU long-term also can cause liver side effects in the adult. Carbimazole and PTU are both secreted in breast milk, but evidence suggests that antithyroid drugs are safe during lactation. There are no adverse effects on IQ or psychomotor development in children whose mothers have received antithyroid drugs in pregnancy. Current guidelines suggest that a pregnant patient should be on PTU during the first trimester of pregnancy due to lower tetragenic effect, and then be switched to methimazole during the second and third trimester due to lower liver dysfunction side effects.